In the last, I believe, 5 to 6 years, we have a new exciting technique that's being popularized here in the United States. It's a laser ablation for the treatment of epilepsy. Laser ablation is not only related to epilepsy patients. It, in fact, was initially developed for tumors, and has been applied in tumor surgery for more than those 5 or 6 years. This is a minimally invasive approach where through a little tiny pinhole, we're talking about maybe 3 millimeters, we can insert a small probe that has a laser on it. And with this small probe, we can ablate or destroy the areas in the brain responsible for seizures, generation, and spread. Theoretically speaking, laser can be applied in any part of the brain, as long as we know that that part of the brain is responsible for the generation of seizures. The determination of that can be done using several techniques. The most common is what we call non-invasive tests or non-invasive results. For example, a patient has seizures and we analyze the type of seizure this patient has. So by analyzing semiology, we can kind of identify a specific area in the brain that is responsible for those seizures. Once we know that, we need to confirm with possible a scalp EEG, which is a test. It takes 2 hours. Sometimes we need a video EEG, but it's a completely non-invasive way. So we can analyze the seizures and also analyze the EEG. And if the seizures, the semiology, matches or localizes a specific area in the brain, and then the EEG also localizes the same area. There are 2 ways of doing EEG analysis. There is something we call recording of interictal activity, which is the activity of the brain between the seizures, and the ictal activity where patients are having seizures and we analyze the seizures while the patient in the EEG recordings while the patient is having seizures. And in general, the brain is very irritable if the patient has epilepsy, and this irritability can be recorded by EEG. So it kind of tells us which part of the brain is irritable, if it's the temporal lobe, if it's the frontal lobe, if it's on the right side, if it's on the left side. And that information we combine with the semiology, with the type of seizures the patient has. So those 2 tests, non-invasive, semiology and EEG, can help us to localize which part of the brain is responsible for seizures. It's a high-definition MRI, which can sometimes show us there is a lesion that corresponds to this EEG and to the semiology. And that becomes a more straightforward case when you have the EEG pointing to the same area that the semiology points, and now you have a lesion that is in the same area. If we combine those 3 tests and they're concordant, we can pretty much build a strong hypothesis that that area in the brain with that lesion is responsible for the seizures. And if this lesion is small enough, we can probably attempt to destroy that lesion with a laser probe. Always risks, you know. So to talk about brain surgery without risks, it's impossible. There are always risks. However, the risks are small. There is always a risk for bleeding, a stroke, an infection, but those risks are small. The alternative to laser is what we call a conventional craniotomy, where we go there and we perform a large craniotomy, and we go there and resect the tissue that is responsible for the seizures. The difference between the craniotomy and the conventional treatment is that The craniotomy is a large opening. It requires a long incision. It requires an operation that has probably 4 or 5 hours in duration. It most likely requires a blood transfusion, and it requires a post-op care that maybe take 2 or 3 days, sometimes maybe 5 days. The advantage of the laser is this is done through a little tiny incision. The patient will leave the OR with a small stitch, and they can go home the next morning. It's a technique that is relatively new. In order to identify and to answer your question, how many percentage of those patients are candidates for this procedure, we need to understand a little bit more in terms of selection of those patients. We believe at this point that every patient that is a candidate for a conventional focal resection can be potentially candidate for laser. However, we still don't know what are specifically the selection criteria, what is the specifically volume that will better treat patients with laser versus patients with standard operation. The problem is the outcome with laser, it's short. We have more experience with the standard procedure. So it's difficult to compare. Right now, if we have a small lesion, for example, hippocampal sclerosis, or a small benign tumor that we believe that's the source of lesions, those patients can be done with laser, and a craniotomy can be avoided.